For our last but definitely not least presentation, Dr. Melinda Telli from Stanford University. Dr. Telli is an associate professor of medicine in the Division of Medical Oncology at Stanford University. She's a director of breast cancer program, and she is also the associate director of the Stanford Women's Cancer Center. Dr. Telli will be giving us an update on advanced breast cancer.
Well, good morning, and thank you for that introduction. It is my pleasure to take us home with the meeting, the last talk. I'll be covering advances from the year for advanced breast cancer. So I think the best place to start is with the antibody-drug conjugates. Certainly 2022 has been another blockbuster year. We've seen the very important data from the DESTINY-Breast04 study showing that trastuzumab deruxtecan improves both progression-free and overall survival in patients with advanced, pre-treated, HER2-low breast cancer. We also saw some updates at this meeting from the DESTINY-Breast03 study looking at trastuzumab deruxtecan in advanced HER2-positive breast cancer, now with a survival benefit. And then at several meetings in the past year, we've seen the first results of the TROPiCS-02 study looking at sacituzumab govitecan in those patients with heavily pretreated advanced ER-positive HER2-negative breast cancer, showing benefits for both progression-free and overall survival. I think it's really significant because these data really impact all patients of the major clinical subtypes with metastatic breast cancer. We've seen some disappointments along the way. We saw updates at ASCO from the PALOMA-2 trial showing that palbociclib, when added to letrozole, did not improve overall survival in the first-line treatment of hormone receptor-positive HER2-negative metastatic breast cancer. And also some important data from the NRG, the BR002 study, which showed that stereotactic body radiation and/or surgical resection didn't improve outcomes in oligometastatic breast cancer. We've seen some new data on novel agents for the treatment of ER-positive, HER2-negative metastatic breast cancer at this meeting. I think very significant data from the CAPItello 291 trial looking at the AKT inhibitor capivasertib added to endocrine therapy, showing improvement in progression-free survival. We've also seen some updates from the EMERALD study looking at the oral SERD elacestrant showing activity in the post-CDK4/6 inhibitor space, while more modest, but particularly more active in the ESR1 mutant subgroup. So to start with the antibody-drug conjugates, I know this audience is probably very familiar, but trastuzumab deruxtecan, it is an antibody that targets HER2, and it is linked with a high drug-to-antibody ratio to deruxtecan, which is a topoisomerase 1 inhibitor. Similarly, sacituzumab govitecan is an antibody that targets an epithelial antigen called TROP2. It's highly expressed in breast cancer and other cancers. It's also linked with a high drug-to-antibody ratio to a topoisomerase 1 payload. And we saw both of these agents receive accelerated approval in the United States based on early phase data, initially for T-DXd in the HER2-positive subgroup of patients, and then for sacituzumab govitecan in metastatic triple-negative breast cancer. So let's look at the data from the year. We saw at ASCO this trial, and I think it's certainly the most significant data of the year, the DESTINY-Breast04 trial. It was the first randomized phase 3 trial of T-DXd in the HER2-low metastatic breast cancer population. So this study enrolled patients who were HER2-low, immunohistochemical scores of 1+ or 2+ with ISH negativity. They had received 1 or 2 prior lines of treatment in the metastatic setting, and they were randomized 2-to-1 to T-DXd or treatment of physician's choice chemotherapy. This was largely a hormone receptor positive HER2-low study, with 480 patients having hormone receptor positive disease and only 60 with hormone receptor negative disease. The primary endpoint was progression-free survival in that hormone receptor positive group. And certainly, there's been a lot of discussion at this meeting about what is HER2 low and how low can we go potentially with the use of T-DXd. And certainly, it is a continuum. But what we're talking about here are those patients, again, with 1+ staining by IHC or 2+ with ISH negativity. And so these were the data that we saw from the DESTINY-Breast04 study, showing that T-DXd improved progression-free survival in both the hormone receptor positive subgroup and in all patients. The median PFS was about 10 months. And not only did it improve progression-free survival, but also overall survival. You can see the data here in the hormone receptor positive group, where median overall survival was approximately 24 months, and in all patients. There was some data that was presented on the hormone receptor negative subgroup. Again, it was a small cohort in this study, but similar trends were observed with benefit from T-DXd in both looking at progression-free as well as overall survival. And in terms of adverse events, we know that interstitial lung disease or pneumonitis is an important toxicity of T-DXd. And this was observed any grade in 12% of patients. There were 3 grade 5 or fatal events in this study, and that was corresponding to a rate of 0.8%. So this was really important data. It changed practice. It led in the United States to the FDA approval of T-DXd for this indication in August of this year. But at this meeting, we did see updated results from the DESTINY-Breast03 study, and this was looking at T-DXd versus T-DM1 in HER2-positive metastatic breast cancer. And so just to review, this was the schema for the study. 524 patients with metastatic HER2-positive breast cancer previously treated with trastuzumab and a taxane were randomized 1-to-1 to T-DXd or T-DM1. The primary endpoint was progression-free survival, and overall survival was a key secondary endpoint. And this is what we saw in this meeting. Quite remarkable that in both arms of the study, overall survival, the median was not yet reached, but at this point in time, based on the separation of the curves, there was a hazard ratio reported of 0.64, showing an improvement in overall survival with T-DXd. And there was updated data on progression-free survival. Again, this is just a remarkable curve showing at this update at San Antonio a median progression-free survival of 28.8 months with T-DXd compared to 6.8 with T-DM1. Hazard ratio 0.33. The response rates were similarly impressive in the T-DXd treated patients, nearly 80% of patients with an objective response, and notably 21% with a complete response. So really quite impressive. At this meeting, they updated some of the safety data, and when it was first reported, the rate of any grade ILD or pneumonitis was reported at 10%. This has increased now to 15%, but fortunately no grade 4 or 5 events at this point in follow-up. And then finally, to talk about the TROPiCS-2 trial. This was, again, presented initially at ASCO This year, this was a randomized phase 3 trial of sacituzumab govitecan, or treatments of physician's choice chemotherapy for patients with hormone receptor positive, HER2 negative metastatic breast cancer. And this was the schema for this study. Patients had to have hormone receptor positive, HER2 negative, advanced breast cancer, at least one prior endocrine therapy, taxane, as well as a CDK4/6 inhibitor in any setting, at least 2, but no more than 4 prior lines of chemotherapy for advanced disease, so a pretty heavily pretreated population. Patients were randomized to sacituzumab govitecan, or treatment of physician's choice chemotherapy. Progression-free survival was the primary endpoint. And we saw, again, over the course of this year, data that has come out from this study showing an improvement in progression-free survival as well as overall survival. When you look at the medians for progression-free survival, it was about a 1.5-month difference. And the difference absolute in terms of median overall survival was approximately 3 months, 11.2 up to 14.4 months. And so certainly, just to summarize, I think that it has been a great year, and certainly the TDXD approval in HER2-low breast cancer represented a bold new frontier for HER2-targeted therapy, the first time we have seen a therapeutic approved for this indication of HER2-low breast cancer. We can also conclude that TDXD has truly remarkable activity in pretreated advanced HER2-positive breast cancer, and we expect that this drug is going to continue to move earlier in the treatment of HER2-positive disease. Sacituzumab govitecan improves survival, though more modestly, in ER-positive, HER2-negative disease that's pretreated. So if we look at how this data fits into therapy sequencing, the data that we have seen this year very firmly establishes TDXD as a preferred second-line regimen in the treatment of HER2-positive disease. And for triple-negative breast cancer, we've already had sacituzumab govitecan as an available option, but now we have TDXD if the patient has HER2-low breast cancer. And so the big question is, what is the activity of TDXD after sacituzumab govitecan? We talked earlier about the payloads with these agents and how they're both topoisomerase I inhibitors, and will we see maintained activity when we give these drugs in sequence? This is a very important and unanswered question. We have a similar situation in endocrine refractory hormone receptor positive HER2 negative disease. With the data from this year, we now have TDXD as an option in the second or third line if patients have HER2 low disease. And again, we have this data with sacituzumab govitecan, which may ultimately become an option. And the question here is the same. What about the sequence of sacituzumab govitecan after TDXD? Will we see the same degree of benefit? So important questions that I think we will be addressing in the years ahead. I want to move on to CDK4/6 inhibitor space, and this just shows all of the first-line CDK4/6 inhibitor trials that have been reported so far. We have seen really remarkable and consistent data in terms of progression-free survival across these studies with palbociclib, ribociclib, and abemaciclib. But we have started to see some differences in terms of the longer-term results on overall survival. And so the final overall survival analysis from the PALOMA-2 trial was reported at ASCO this year. And if you recall, this study enrolled patients with advanced ER-positive, HER2-negative breast cancer. They had to be postmenopausal with no prior treatment for advanced disease, and they were randomized 2-to-1 to palbociclib and letrozole or placebo and letrozole. The primary endpoint was progression-free survival, and this study design and sample size had about 90% power to detect an improvement with the addition of palbociclib. Overall survival was a secondary endpoint, and the power here was approximately 80%. And so this is what we saw at ASCO. There was no improvement in overall survival with the addition of palbociclib to letrozole in the first-line setting. Numerically, there was about a 3-month difference in median overall survival favoring palbociclib, but really the hazard ratio was negative at 0.956. There was a question about this study because it did, unlike the others, enroll patients with a short disease-free interval from their prior adjuvant therapy. And one question was, how much of a contribution did that make to the results? It was just over 20% of the patients that had a short disease-free interval that came onto the study. And this is a post hoc subgroup analysis, and it included just a subset of patients from Paloma 2 as well as Paloma 1, but did show a suggestion that in those patients with a disease-free interval of at least 12 months, that there was an advantage with the addition of palbociclib. We also saw an update this year at ESMO from the Monarch 3 study. So this study enrolled patients postmenopausal. They had to have a disease-free interval of at least 12 months, randomized to abemaciclib with an aromatase inhibitor or placebo with an aromatase inhibitor. Primary endpoint, again, was progression-free survival. And this was the data on overall survival from the second interim analysis. This is still preliminary. Patients are being followed, and the survival data remains immature. But what we saw at ESMO was certainly a separation of the curves with longer follow-up. And at this point in time when this was reported, the hazard ratio was 0.75, but it did not yet cross the boundary for significance. And again, a number of the patients are still have immature follow-up. So a big question has been, since ASCO, which CDK4/6 inhibitor to choose in the first-line setting, and we had a debate here at this meeting. I'm not sure that we have an answer, but I think it is important to say that we don't have any head-to-head comparisons, and so that is certainly difficult. But what we do know is that we saw an overall survival benefit in all of the ribociclib trials. And this will likely also be evident with abemaciclib as we have further follow-up coming in from the Monarch 3 study. What happened with Paloma 2? Was the lack of an overall survival benefit with palbociclib due to trial-related factors, or does it represent a true difference with this drug compared to the others? There are a number of questions. Was the study adequately powered to detect an improvement in overall survival? There was a big problem with this study with a lot of missing survival data. How much of an impact did that have? And what about that inclusion of patients with a shorter disease-free interval? How much impact did that have? I think these are going to remain points of discussion as we move into the new year, but I think it's certainly important to note, and I think we all agree, that there are important toxicity differences between these drugs that are always important to consider in making your choice. I wanted to spend a few minutes on this study presented at this meeting, Capitello 291. I think it's a really important phase 3 study looking at the AKT inhibitor capivasertib with fulvestrant for those patients with ER-positive, HER2-negative advanced disease. You can see the schema of the study here. This trial enrolled those patients who had recurrence on or within 12 months of the end of their adjuvant endocrine therapy, or had progression while on a prior aromatase inhibitor for advanced disease. They could have up to 2 lines of endocrine therapy, up to 1 line of chemotherapy. A CDK4/6 inhibitor was allowed and actually required for at least 51% of the patients. No prior SERD, mTOR inhibitor, PI3K inhibitor, or AKT inhibitor. Patients were randomized to the AKT inhibitor capivasertib plus fulvestrant versus placebo and fulvestrant, and capivasertib was dosed at 400 milligrams twice a day on a 4-on, 3-off schedule. There was a dual primary endpoint in this study, looking at progression-free survival in the overall population as well as the AKT pathway altered tumors. And so patients fell into this group if they had at least one qualifying mutation in PI3 kinase, AKT1, or PTEN. And this is what we saw. So this is the progression-free survival in the overall population, clearly favoring the addition of capivasertib with a median progression-free survival of 7.2 months compared to 3.6 in the placebo fulvestrant arm. The hazard ratio here was 0.6. And when you look at the AKT pathway altered population, a very similar result in terms of benefit to capivasertib. The hazard ratio was somewhat lower at 0.5 for this subgroup. And while immature, I found these data very interesting, showing an early suggestion of separation of the curves in terms of overall survival. So this will be important data to follow up looking ahead. What is most important, I think, with this agent is that it had a overall very good safety profile. Diarrhea, nausea, rash were the most common adverse events. Diarrhea occurred in up to 9% of patients, grade 3. But importantly, when you look at hyperglycemia, which has really been a problem with other agents targeting this pathway, this was less frequent and high grade in only 2.3%. So certainly if we look at this toxicity profile and compare it to what we see with alpelisib, this certainly looks much more favorable. And then just to touch on the EMERALD study, this was previously reported at San Antonio, the initial results, and we saw an update at this meeting. And this was a phase 3 trial looking at the oral SERD elacestrant versus standard of care endocrine therapy for patients with ER-positive, HER2-negative metastatic breast cancer. And this oral SERD landscape is very crowded. There are a number of studies ongoing in both the advanced disease, and we're starting to see trials moving forward in the early stage setting. All of these studies in the advanced or advanced pre-treated setting had different eligibility criteria, selected patients differently. Some mandated that the patients have had prior CDK4/6 inhibitor. Some allowed or didn't allow prior fulvestrant, as well as prior chemotherapy in the advanced disease setting. And so this was the schema for the EMERALD study. It enrolled patients with ER-positive, HER2-negative advanced breast cancer who had progressed on or after 1 or 2 lines of endocrine therapy for advanced disease, one of which was given in combination with a CDK4/6 inhibitor, and it did allow patients to have up to 1 line of prior chemotherapy. Patients were randomized to elacestrant 400 milligrams a day or investigator's choice endocrine therapy, and that could be fulvestrant or any of the aromatase inhibitors. There were 2 primary endpoints, progression-free survival overall and in the ESR1 mutant population. And at this meeting, we saw some additional analyses from this trial, really trying to get at the question of whether the patient's tumor had demonstrated prior endocrine sensitivity or not. And so looked at dividing patients based on the duration of prior CDK4/6 inhibitor use. And what you can see that in all groups there was an advantage in favor of elacestrant, but this was certainly more marked in those patients who had a long prior duration of CDK4/6 treatment. And then looking at those patients specifically with ESR1 mutations, again, based on by the duration of prior CDK4/6 inhibitor use, you can again see advantage to elacestrant, which becomes more substantial in those patients with more endocrine-sensitive disease, so the longer duration of prior CDK4/6 inhibitor. And finally, I just wanted to talk about this study. I think it's an important trial that was presented at ASCO from the NRG. This was the BR002 trial, which really tried to address an important question for patients with oligometastatic breast cancer. And so in this study, patients who had controlled local regional disease and no more than 4 metastatic sites who had been on systemic therapy for up to 1 year without progression were able to come into this study and were randomized to either symptom-directed palliative therapy, local palliative therapy as needed, with standard systemic treatment, or total ablation of all metastasis with standard systemic treatment. This was a randomized phase 2, phase 3 design, and the idea was to evaluate the initial group of patients in the randomized phase 2 to make a go or no-go decision into the phase 3 trial. So in this study, patients, again, had to have no progression within the first year of their systemic treatment, and they had to have metastasis that were amenable to either resection or stereotactic body radiation up to 5 centimeters in size. Patients with brain metastasis were excluded. And so what did we see? The results were unfortunately disappointing. There was no improvement in progression-free survival with this strategy of ablating all of the oligometastatic sites. The same was observed for overall survival, if anything trending in favor of the standard of care arm. And so just the last group of conclusions, I think that we will likely see in the new year the first approval of an AKT inhibitor, capivasertib, for our patients with ER-positive, HER2-negative metastatic breast cancer. I think that this is going to be a really favorable option for patients post-CDK4/6 in the second line. And certainly this drug has many advantages over alpelisib in that it has a much better toxicity profile. The oral SERDs at this point in time are showing only modest monotherapy activity. However, we are going to be seeing these drugs in earlier settings in combination, and then again in the early adjuvant setting as well. So it's going to be really important to follow this space as we move forward. And then finally, we saw from the NRG that SBRT and/or resection doesn't improve survival in oligometastatic breast cancer. And I think this is important negative data for our clinical practice. And so with that, I would like to thank you all for your attention. It has truly been a wonderful meeting, and I look forward to all of the great advances we're going to see in 2023. Thank you.